Welcome to Simcast, a podcast brought to you by the Society for Imaging Informatics and Medicine.
Greetings, Simcast listeners. Jason and I got to sit down recently with Greg Toffner, someone who's doing some really interesting work in Canada's far north. Today, he talks to us about the concept of task shifting, and he's going to explain to him more detail how they came to that. It's all just very fascinating. Greg is a PhD candidate in global health at McMaster University in Ontario, Canada. He is president of CEO for the Ontario Association of Medical Radiation Sciences. He has been working with the government of Nunavut since 2017 to administer a task-shifting X-ray training program across the Arctic to help improve quality and access to diagnostic services. His research explores the effectiveness of the task-shifting program in Nunavut using a mixed methods explanatory sequential design that could help inform health policy and practice, particularly in remote underserviced settings. I hope you find this episode as fascinating as Jason and I did, and you learned something from it. Greg did mention that he's also happy to answer any questions, so you're more welcome to reach out to him afterwards if you have anything that you're wondering about. Enjoy.
Welcome, Greg, and welcome to this very special episode where we're teaming up Imaging Informatics Unplugged and Simcast. It's like a crossover episode of a sitcom. I'm excited to have you on the episode. We saw you present last year at MIIT, and Mohammed actually was the one that kicked this off and thought this would be a great discussion for our podcast here. And so maybe to set the table for the folks that are listening, could you give us a recap of the concept of task shifting in Canada up in the high Arctic, and what is the main mission of what you've been setting out to do in your organization?
Sure. First of all, thank you for having me. It's a pleasure to be here. It was a great conference presenting last year with the Medical Informatics Group. So yeah, I'm pleased that there's some interest in the study and the work that we're doing up there. The task shifting that we're doing is we're training local people from the remote flying communities, 25 communities across Nunavut, how to perform basic X-ray services. So we know there's health disparities and there's gaps in services in these very remote settings and communities. And so we're always looking for solutions to try to improve health services delivery in those regions where we know people just don't have the same level of access to specialized care, whether that be, having highly trained practitioners that are available like we have down here in the South, or just general accessibility is a really big problem because they have to be brought out for many of the health services. So this was something that we started about 6 years ago, to address the gap for access to basic diagnostic services. So it hasn't worked in the past where we don't have medical radiation technologists, as an example, like we have in the southern hospitals and clinics to access X-rays and CT scans and everything else. So people would have to leave the community to get very basic services like a chest X-ray or a hand X-ray. So there's a cost to that. There's also, you can look at health outcomes and patient care and all of the effects of not having the service locally available. Over the years, we've had iterations of programming where we've trained physicians and nurses up in those communities. I've been involved in training up in Northwestern Ontario, First Nations communities, as well as the Northwest Territories. And so over the years, we've done some informal training where we train the doctors and the nurses who are working up there to perhaps be able to do this. But the problem was it just wasn't sustainable because they're very transient. The nature of that work is very transient. So the physicians and the nurses that go up to those communities largely don't stay for long periods of time. And so you would train them and then they would leave and then the community would be left with nothing again. So the idea was, why don't we train local community people and build the community up and make, in this case, the Inuit members of the community part of the primary healthcare team and create a sustainable resource. And if we can train local people, then they would be there to provide the service for the nurses and the physicians that are in those acute care settings. Because each of those very small remote communities have a small health center. They're like acute care centers. So the idea was we train local people and maybe we can get them becoming very competent and proficient at providing the service. And that's going to improve quality, improve access, and create a sustainable resource in the community while also building up the community. So the concept of task shifting is that we're shifting a skill set to another person. So part of the study that I'm doing with my PhD research is actually to assess this program and look at the effectiveness of the program of training non-traditionally trained healthcare professionals to perform a task they weren't formally trained to do. So for example, you need a university degree to take x-rays and perform ultrasounds and CTs, things like this in normal situations. Like it's a regulated health profession that requires that. The concept, really to take someone that isn't as educated to perform those functions in a limited scope, to perform them really well, is the concept of task shifting. So you can see that being applied in all kinds of different settings in different countries. So especially in areas where, again, they desperately need access to services and they just don't have it. And so, you go and look at places like Africa, and they've trained community health workers, for example, to performing minor surgical procedures and to hand out HIV medications and different pharmaceuticals and perform various other procedures. And that being said, we see task shifting happening across the board where, you see nurses performing tasks that were performed by physicians, or you see general practitioner physicians performing tasks that may have been performed by specialized physicians. And so there's a lot of variation. We saw a lot of that in COVID, actually, because we saw, there's been a gross shortage of health professionals across the board. And then we saw expansion of scopes of practices, and nurses and MRTs and physiotherapists and doctors and nurses all of a sudden were asked to perform different functions that they might not have formally been trained to do in the past. And so those are all examples of task shifting.
Thank you, Greg. I think you opened up the door for a lot of follow-up questions, but I'm going to start with one maybe where we take a step back. Some of our listeners may hear the word remote and they start to assume that we're talking about rural settings. But in this case, remote is really remote. So maybe you can paint a mental picture for our listeners as far as, what the geography looks like, population, weather, what your trip to go up there looks like, and the existing health disparities that you've seen, things like life expectancies.
You're right. It's different, like being up to most of the communities over the years. The land is very spread out and it's frozen tundra. So there's no trees, and you're literally out on the Arctic Ocean, and there's a bunch of islands everywhere, and that's Nunavut in the high Arctic. The populations can range from a few thousand, and the smallest community has about 120 people. Most of them have a few hundred, and then, like I said, there's some that are 1 or 2,000. Overall, the population across all 25 communities, which would include the larger centers like Iqaluit and Rankin Inlet and Cambridge Bay, it's about, I think it was around 30,000 total. So if you actually look at a map, and I encourage the listeners to look at a map, you'll see how large that land mass is. And then you can compare it to a place like Ontario and how densely packed that population is relative to that small population of 30,000 dispersed and spread out across all of that geography. And then depending which community you're in and which month you go up, you're looking at 24 hours darkness for several months, and -50, -60, regular blizzards happening. I've been stranded for weeks in these communities over the years, and you got to wear the full Arctic gear when you're out there, and there's 90-kilometer-hour winds at -50 or -60, and you're wearing like a tunnel hood and covering your face. It's not rural, it's remote. There's definitely a difference between rural and remote.
I have been fortunate enough to be able to volunteer with Rad Aid, which is an organization that you mentioned Africa, so that, there's different chapters and initiatives that are helping promote more equitable health services in some of these regions. And I think sometimes we don't really appreciate how those types of disparities exist within our own country. And I'd love to hear you expand a little bit more on what type of disparities you would see in Nunavut versus Toronto. And also, have you, as you've applied this task shifting program, looked for other societies or initiatives that are deploying this in, LMICs
Yeah, I think starting this program up in Nunavut and then working on my PhD research really opened up my eyes beyond what we were doing here. Because a part of that, obviously, I had to do extensive literature review and research into what was happening in other countries, and just the concept of task shifting, what that means, and what that means in different geographies and different locations. And so this was really important research. And I know, Dr. Koff and others at McMaster University and on the committee are really excited about this because we believe it's a concept that is transferable, meaning that there's obviously disparities in skill mixes and skill sets and access to resources in all kinds of different settings across the world. And publishing this kind of data can be really significant because if the program is successful here, this concept of task shifting we're applying it to X-ray services, can be applied to almost any health discipline, which can be very helpful in hopefully improving access to services and quality of services and inevitably health outcomes, because people are going to get access to services faster and then they're going to receive treatment faster in whatever regard. So it's been going really, really well. And we've actually expanded the program. And now you may have this question for later and I'll answer your other question, but you're getting my wheels spinning. We've recently expanded the program from when I spoke to include now to train graduates of the X-ray program to also perform blood collections, CGs, specimen management functions, and applying Holter monitors. And they've created a full-time role for people who have taken the training. I mean, there are huge differences in the population, and it's all based around access to services and lifestyles and how people live. But the life expectancy is about 10 years less for Nunavut residents than it is for the general population in Canada. So they're already, you talked about inequities, they're already at a disadvantage there. And I think if you look at the Canada Health Act and what we try to achieve in Canada is that everyone, any Canadian citizen, wherever you live, deserves the right to the same access to services and the same quality of services. And I think that's what we're all trying to achieve here. And those challenges, overcoming those challenges of the geographical barriers and the harsh conditions that people live in up there. But yeah, what else the smoking rate is significantly higher in Nunavut, like 50% higher. A lot more people smoke. Respiratory diseases such as pneumonia, influenza, bronchitis. So I have a statistic that, average rate of death per 100,000 population. So you'd scale this accordingly. Per 100,000, death rate is 45 for all of Canada versus 183 in Nunavut. So it's like, 3 times higher. And obviously the suicide rate at 10% across Canada, 64% in Nunavut.
So these are glaring differences and they speak to a lot of challenges beyond task shifting. These are societal challenges where we need government assistance sometimes in programs. Could you speak to a bit about how important was the government recognition and policy supporting in making this basic radiological technician role viable? I'd love to hear more about the government role in that.
Yeah, it's critical. It's so important. And, when I was when I was going through the literature review and doing the preliminary research on this around where has task shifting been successful and where has it not been successful and why is that? And so the literature says, and in my experience, what I'm seeing now over the past 6 years is where there is government support for the program. And what I mean by that is they're actually recognizing the role and it's being written into policy. It shifts the culture and it becomes a norm. It becomes a social norm and it becomes an expectation, and that's what makes it successful. And so in those jurisdictions, many, like I think I told you when I first got involved, we were going up and doing informal task shifting and we're training people how to do some x-rays and sort of off the cuff, and that helps them out locally. But no one really knows about it and no one understands it, and they're not recognized. They're just sort of doing it and off the radar, off the grid. So then on a volume scale, it's not recognized. You run into problems. And especially when you're going into, areas where there's people who are traditionally trained. You have locum physicians, locum nurses. They don't understand anything about this. And in fact, I remember when we first went up, there was a lot of resistance. And like, what do you mean? Because like when we talked about the task shifting, we talked about having, local staff. When I say we have local people, so they are, let me just say they are employed by the health center, but they could be in the clerical position, clerk interpreter, they could be the custodian. These are the people we're training to do the x-rays. So imagine if you're the doctor or the nurse up there and you don't know anything about this and you're used to working where everyone's regulated and educated, and then it's like, what? The janitor's taking the x-rays? How inappropriate is that? And so it was just a lot of people had to process that and to understand it and to understand the concept of task shifting and how this benefits their practice by supporting it and embracing it. And so it really is an all hands on deck for these things to be successful, and shifting that culture takes time. And there was a lot of consultations that had to take place with the government, with people inside the government, but also with the staff, and getting them to appreciate and understand what it means and what it is, because they need to support them. They need to support the people being trained and build them up and make them feel good about themselves. And they're going to perform that task really, really well. Then that benefits the nursing and the medical practice, because they're going to have that service available to them, rather than them trying to do something arbitrarily off the side of their desk and end up having really, really poor quality and something that's undiagnosable. It really is an important feature, and we've seen that, and it's taken years. It's taken, 5-6 years, and now we're seeing the term BRT showing up in human resources documents. We're seeing it in policy. And when we first started this, people were confused. They didn't know what was going on, and the nurses wanted to take the x-rays, and they just didn't know, right? But now, because of the government support and because it's now into the documentation, it shifted the culture so much that it's now an expectation. Everyone knows what BRTs are up there. And when they need more people taking x-rays, they're asking for the training, and they have no interest in doing it themselves. So it's huge. It really is huge.
And that brings up a really good point, Greg. So I'm curious, like you mentioned in this case, those BRTs come from different backgrounds. Example, the janitor. How do you compensate for those gaps in education as you train these people? And the opposite side, how do you decide what procedures are safe for them to perform versus where you draw the line?
So that took a lot of consultation at the beginning. And, we've been doing this for a few years in other jurisdictions. So we learned, and we had to determine, to your point, what would be an appropriate level for the people we're trying to train. And so we drafted a curriculum and we simplified it. And so traditionally, a person that's going to take x-rays, you're going to do a 3 or 4 year program of study. And so like when you look at what's that curriculum? Well, they learn about physics and radiation biology, and they learn about all the positioning of all body parts, and it's quite extensive. And we had to take a look at that and say, okay, well, what do these people need to know to be able to perform the functions? They may not understand fully the theoretical concepts behind everything, and they may not have the critical thinking that an MRT may have to perform these tasks, and that's okay. What we're trying to create is someone who can almost perform a standard operating procedure, if you will. So pilots are trained standard operating procedures, and it kind of works like that, where if we can create some really simplified standard operating procedures that they can become really familiar with and then become really competent with through repetition, they can become really good at it. And that was the intention. So we created our own positioning manual for all of the approved procedures. And the procedures were done in consultation with the Medical Advisory Committee in Nunavut out of Iqaluit, and in consultation with the radiologists who report the x-rays out of Nunavut, out of the Ottawa Hospital, and with my organization at the OMRS. So there was that broad consultation. There was also some limitations with what we could do, because you also have to remember we are using very basic mobile x-ray equipment up in those communities. These are not sophisticated x-ray rooms that you're going to find in a clinic or a hospital. And so there's limitations currently with the equipment that we're using up there. So they have a very low kilowatt rating, and that just means that there's just not a whole lot of output or power to be able to penetrate really large body parts. We don't use grids. And so there was that combined with, these are going to be limited scope BRTs that we're training. And so what is the capacity that we're looking for here? And so what could be done in the community? And then anything beyond that, they would still be flown out for those services. But you look at the statistics, and the majority of the stuff that really is meaningful. And, I refer to those respiratory diseases, just getting a chest x-ray, it can make in a timely manner can mean the difference between life or death, or whether they're staying in the community or whether they're being flown out of the community. So there's just a lot of implications for all of those things.
Really, the way you're describing the training program and isolating it to the specific core skills that they need to be able to perform this procedure, it kind of reshapes how the democratization of education can be deployed. And you can really, what are you seeking to accomplish? We want to have good images acquired, or I'm curious, based on what you described as far as the infrastructure, it sounds like you likely don't have any AI tools available right now. I'm curious if that's something you've explored, where AI could be useful in assistance with the acquisition itself, and that it can confirm if, the Doppler is positioned properly or whatever the case may be.
Yeah, thanks. No, yeah. So this concept requires a lot of hands-on and a lot of in-person training. So we run the program over 3 program phases, and we do have a blended learning approach. In the early days when we first started the program, the connectivity in the network was just so poor. We couldn't really have a blended learning approach. We tried, but depending which community you went into, it was taking them 10 minutes to download an image, and that just wasn't feasible. And so we had to shift really all in person. But we run the program over 3 phases, and what we do is we take that curriculum that we created, which has, simplified. We've simplified the curriculum for more of a lay person, so someone can understand that. We have people in our program that range from a grade 6 level of education to grade 12. There's a few that have done some post-secondary, but the majority have some level of high school. And so, we have to create something that's going to work for everyone. And so a lot of people use the pictures and to identify and to be able to learn and understand the concepts. But we simplified that and created a simplified version of the radiation biology, as an example, the physics, how to understand what is an X-ray, what is kilovoltage, what is MAS, what are these parameters, how does that relate to dose, and how do we translate that into something that will just make sense to them and that they can understand at a human level. And whereas MRTs are going to go much more beyond that, and they're going to be doing dose calculations and mathematical calculations for a lot of these things, and we don't get into that. But what we want them to understand is the concepts. And so we water it down into hopefully giving them what they need. And then we do that with the positioning as well. And instead of having this massive 3-volume, 10-inch thick book for all these views with complex instructions, we've simplified that into very basic instructions, almost like a recipe manual. And so just getting them to understand that over 3 program phases, we send an instructor up into the community, and they're going to teach them those concepts over a week, and then, go through all the positioning with them. So in the first phase, they're a little bit like deer in the headlight. It's information overload. We don't expect them to know everything, but we want them to be introduced to the concepts. And so the instructor is just going to teach them and show them and get them comfortable with the X-ray room and the X-ray machine and how to actually use it, and show them all the positions. And they learn all the anatomy. That was the other piece. We created a coloring book, so they have a coloring exercise. So they learn all the bones of the body, in a way that is just more meaningful and more impactful for this type of group. And so they'll get it. And we do a lot of image critique. Then the instructor leaves, and then ideally there's someone there that's graduated already or in a higher level phase that's performing the X-rays. And then this new person will shadow that person over the course of a couple of months. Then we send the instructor back for a second phase, and they spend a whole nother week with them, and they essentially repeat everything that they learned in the first phase. But the difference this time is now they have been introduced to it, and they have spent a couple of months observing And what it's doing is giving them context. So now the instructor, when they teach them again, it's going to resonate with them more. The concepts are going to actually mean something, because in that first phase, they can't identify with it. Like KV and X-ray settings, exposure charts, just going to go over their head. But now, after actually seeing it, we reiterate it and it sinks in a little bit more. And so we do this deliberately in terms of our instructional design, because they're learning the concept. And then the instructor in phase 2 is going to spend less time showing and having them show us. So now we really enforce them to, read the book. What does the book say? What does the book say? To get them used to using that book and becoming independent. So then the instructor leaves again, and now they're able to actually perform some procedures, and they will have a self-assessment form. So what happens is they'll perform procedures, and then they have to fill out the self-assessment form and essentially assess their work, assess the images that they took. Then they send this form to whatever regional center in Nunavut that they're a part of. All the 25 communities, they're broken down by region, and whether that's the Baffin region, the Kitikmeot region, or Kavalik region. And so Iqaluit is the hub hospital in the Baffin region, as an example, and Cambridge Bay and Kitikmeot, and Rankin Inlet in the Kavalik region. So there's MRTs at those sites. And so the students will send their self-assessment form to whatever regional site. The MRT will assess their images and provide them feedback, and then they send the form back. So they get a continuous loop of feedback. And so then this will go on. At this point, they have to perform a minimum of 60 procedures, and those are audited. And so they have to be to the satisfaction of a quality control MRT that we have on staff at the OMRS. So it might take them 150 images or procedures before they actually meet the standard. It might take them 60. And so there's variations on how long it takes people to get through to the next phase based on the size of the community. The smaller communities takes longer because they're not as busy and they're not doing as many procedures. The larger communities are very busy, so that they can go a little bit faster. Interestingly enough, we looked at how long does it take students to get through with the program. And I was actually surprised, but because the study period went through the COVID times, I think that caused major delays. But actually, we had a window of 2 years to 6 years for students to actually get through the program. And that's an important consideration as well, because a lot of people just think this is like a weekend workshop. They're going to teach me how to do x-rays and snap our fingers, and within 2 days, they can do x-rays. But actually, no, that people in this program have to work very hard to achieve to get to graduation, to achieve the result. And it's going to take them a couple of years to graduate through the program by the time they meet those competencies. But after the phase 2 and they've met the competency requirements, then what happens is the instructor will go back in again, and that's where they're going to perform the competency assessment. So at this point, they do a review of all the material, and the students have to effectively, over the course of the week, perform every single procedure perfectly in the book to graduate. And then when they pass that competency skills evaluation, they graduate, and we host an actual convocation ceremony for them in their community and invite the community mayor and all the staff in the health center, the physicians and the nurses, and they invite their family and friends. And we treat it like an actual convocation that you would get when you graduated college or university. And I don't want to discount that either, because it's so, so important. It's so meaningful for them. And not only is it meaningful for the graduate and recognizing them, but it's so meaningful when, we talked about earlier about getting this increasing exposure for the program and getting it recognized and getting it written into policy with the government. And, how do you do that? Well, you do that through things like this, because the nurses and the doctors, and they're all there and they see how important this is. And I've attended many of these, and then I've had, physicians and nurses approach me after and say, wow, this is so impactful. This is amazing. I had no idea that it was this intense, that they actually had to do a multi-year program to get through it. So again, it just all goes with shifting that culture and contributes to our goal of getting the position recognized and shifting that culture so that the role is successful.
You're bringing up a good number of topics I want to follow up on, but I'm going to start with this one. You said the program was intense. Obviously it is. And it's funny that you mentioned, 1 to 2 years, it's not a weekend workshop. The other word I would describe the program is super well thought out. I could tell you've iterated over this over and over to refine it. I also remember that in your presentation, you had written 2 books on the matter. I'm actually reading it off my screen. Basic Radiological Technician Theory Manual is the one book, and the Positioning Manual is the other one. You also just mentioned things like coloring books, even for like those exercises. So obviously you've got massive amount of resources that have been developed, and it sounds like almost like a bit of a blueprint. I'm actually curious if you have any plans, and I'm not trying to impose, but any plans to make those blueprints readily available, because I could imagine that not only are there other parts in Canada that would find this useful, but really other parts of the world. Like I imagine there are many, many countries around the world that have similar problems that could use to, maybe copy some of this homework if that's something you've thought about.
Yeah, absolutely. People have become aware of the program, and I've had several requests from both RadAid and a few mission groups have approached me and said, we're doing this mission group, this mission workout in Africa, and we're going up to train some people how to do some basic x-rays and ultrasounds. And we heard of your program, could we use your curriculum? And absolutely, we shared it. In fact, we donated several of our books. So the theory manuals and positioning manuals, we donated some boxes of them, and the trainers or whoever contacted us actually took them up and used them, and they were very thankful. And there's an example of, I think they were, they're desperate, and they're running informal training with people, and they don't have anything, and they would have went up there with nothing, trying to just figure something out, because something's always better than nothing. And so if we can help in any way and share any of our content, we absolutely do. And so whatever they're doing there now, they're probably at least have some sort of structure that they can use that would be really helpful to them.
Amazing. And now the part I'm very excited about to ask. So I attended your presentation almost a year ago to the day, and obviously a lot I'm sure has happened in a year. You alluded to that earlier. So I'm now very curious to hear, what updates do you have for us?
Yeah. So as you know, I have been running this study as part of my PhD work. And so we're interested in, learning from this program. We know that there's been iterations of this type of program happening, but no one's actually really studied it. And there hasn't been a whole lot of data to come out of that, which I think was a really big opportunity for us, because if we can look at the success of the program and get that out for people to see that information sharing might be very useful in other jurisdictions. So last year, I was going up and I was doing some of the data collection. And so just to give you a refresh, I'm doing a mixed methods explanatory sequential design for the study up there. So the study period that we're looking at is when we started the program in 2018 up until the end of 2024, just because that's how long it takes to get all the ethics approvals and everything. And so in terms of cutting it off, but we're looking at the program over that period of 2018 to 2024. Using the explanatory mixed method sequential design, what that means is that we use some quantitative methodologies to collect data around the program that will help inform some qualitative information, some qualitative data collection in terms of, in this case, I did some personal interviews, and then collectively get some really good information about the program around the success of the program, and if it works, if it doesn't work. And I think the quantitative data that we're collecting will show statistically things like volumes of procedures by community and how many types of procedures. So why do we need task shifting up there? How many procedures are they actually doing? Is this something that is significant? Is it worthwhile? We want to know, what is the volumes of procedures we're performing year over year by community? What are the types of procedures that we're performing year over year in communities? And how many of these types of procedures, what are the top procedures are being performed? Also, part of the quantitative was we wanted to assess the quality over time. And we ran surveys with the radiologists at the Ottawa Hospital to try and assess what the quality was like, and then what were the issues, if there are any issues, and collecting all that data. And then obviously all the demographic data collection was important too, because we're interested in learning about how many people are we training. We know they're all Inuit status, but what's the gender mix and what are their roles in the health center? So who are the types of people we're training? What is their education level? Like, all of this is just very interesting, because it really shows with the training program and the graduates we're producing, it's quite remarkable how we can train someone that has virtually no background for this at all and make the program successful. And why is that? And what are the reasons for it? And so then I think that's why we get into the qualitative measures and the personal interviews, because we really were interested in, it's great that we have all this black and white quantitative information, but the stuff, kind of the things that we talked about earlier about, how it's successful, all the kind of the soft skills and those areas that people don't necessarily think about. And what we did is we did 25 interviews across 7 different communities. That all happened last year. Actually, I think when I did that talk, I was in the middle of it. So I was traveling to the communities and conducting the interviews. But we did 25 interviews with 3 different cohorts. And the 3 different cohorts were the health professionals, the health providers that were actually working in the communities. So there was 9 of those. We did 9 interviews with health providers. So those could be administrators, physicians, nurses, NPs that were involved in the healthcare delivery and working alongside of the people we're training. And then we did interviews with 8 general community members. So we wanted to know from a community member perspective, do they even know about this program? And what do they think about it? What does that mean to them for the community that we're training local people to perform the services in their community? And then we did 8 interviews with graduates of the program to get their perspectives. So collectively, it was quite a process. Like, you end up with hundreds and hundreds of pages of transcript. And then those interviews were digitally recorded and then transcribed, fed into a software program called InVivo, which we use to analyze qualitative data, and then going through the steps of coding all of the data. And so doing topic coding and then evolving that into thematic coding, and then evolving and arriving at themes basically for that. And what we're doing in that process is really, again, why is the program successful? Why is it not successful? And so, fundamentally, a lot of people will just look at, okay, well, what's the training program made of? And what's the curriculum? And why aren't people passing, or why aren't people failing? And often you don't necessarily know that. And that's the reason why we did the personal interviews in terms of answering those questions. What's come out of it is several themes that were really, really important. And in terms of how is our curriculum, how is our training, how is this task shifting program successful, and all the things we talked about earlier about getting buy-in from the other health providers and the people that are in the community health centers, and making sure the students have support for the program and they're feeling good about themselves. And it's more than just the program, and the government's recognizing it, and the role is recognized in HR documents and policies, and then that shifts the culture. And all of these things collectively add to the success of the program. If we didn't have that, it wouldn't matter what kind of curriculum we have, it wouldn't be successful. So asking those questions, we came up with pride was huge. There was immense pride among the community members and the graduates. And we originally, it was sort of a last minute decision that, I hadn't intended to interview community members, and then we did. And I'm so glad that we did, because we learned so much. Just even asking a basic question, because we talked to community members that were not attached to the program in any way, and just randomly found community members, would you be willing to do an interview? Just asking a question about, do you know about this program? Have you heard about this program? Do you know that we have local people being trained? And it was every single community member knew about it. So that was very telling, because that means that these are small communities. People know everything, and people were aware. And so they were sharing that they were so proud that they had people their own people being trained to provide this service and to be a part of the healthcare team. And then that was actually something that was creating interest and generating interest among the community for continuing education and to do more things and to get the young people involved in education. So the work that we were doing was creating a lot of these indirect benefits that were all very positive. Some of the other things that came out were they appreciated having someone there that could speak their language and that they could identify with, because they were more comfortable with having a local person be involved in their healthcare relative to a transient worker that they didn't know. and just they felt more at home and more comfortable, and it was really meaningful. And then that had an impact on their perception of patient care and the kind of care they received. And then the graduate pride, it was just so incredible, and doing that, having that convocation ceremony for them at the end was so meaningful for them, and they were just so proud. And what does that do? Well, that creates an internal rewards system. So they're not being forced to do this work. And, one of the questions we asked was, is financial compensation important to you? So of course, the majority were like, well, yeah, we wouldn't mind some extra money, but if there's no money, we still want to do it because we know it benefits the community, and we would do it anyway. Because when we first started doing the training, there was no financial compensation. So imagine completing a 2-year program or more, and then you're just told you're now doing the x-rays in addition to your other role in the health center, but we're not going to pay you any more money. And so what I'm saying is that whole thing about shifting the culture and getting them feeling good about themselves created that internal rewards for them where they actually wanted to do the x-rays and they felt good about it, and it made them feel good about themselves. And when someone feels good about the work they're doing, they want to do it. They're going to do the job better. And that then has an impact on the quality. And so these are the kinds of things that we learned through the personal interviews. So improved local health services, obviously, the access was improved immensely. The successful integration of the task shifted role, recognition of the task shifted role. And there was particularly because we interviewed different cohorts, and there was universal conversations about what we talked about earlier is this task shifting thing, is this transferable? And so there was a lot of discussion about opportunities for future task shifting. And I think I mentioned earlier in the podcast a little bit about how we've already expanded the role of the BRT. And for the first time, the government has recognized it as a distinct role, and people who are finishing the postgraduate training are now being paid a full-time salary to basically perform the x-rays and the lab tasks and the ECGs and those ancillary functions. So it's created meaningful employment in the health centers as well for local people that are living there.
Greg, that was amazing. Thank you very much. We could sit and talk about this for days. I really mean it. I would. But I'm actually going to ask you a little bit of maybe like a controversial, perhaps, question. The elephant in the room when it comes to informatics is AI. I'm actually curious if you already have any kind of AI being used here, or perhaps you see a role for it in the future. And if the answer to both is no, that's perfectly fine. But I thought I'd ask the question anyway.
I think you asked it earlier, and I didn't get to it because I was running off in other directions. So what I was saying then was that because we had technological challenges, we've had to really do a lot of hands-on work in face-to-face training to graduate people through this program. And I think that's always going to be existent. But what we found over the last 5 years, the infrastructure has improved significantly. So we are rebuilding our online learning platform and moving forward. And in fact, the new training program, the postgraduate training that we've been doing, is fully blended. So now they've graduated and we're training them the lab skills, the blood collections and specimen management functions, ECGs. There's a big element of online now where we're doing that. And then we've created a nurse preceptorship program, and we still send an instructor up to do the initial training, but then we have a preceptor do the training. So what I'm getting at is that we are going to shift, I think, the training ongoing. We're trying to move a lot of the theoretical concepts to be more online so that the instructor can spend most of their time when they go up doing all of the practical, which is so important. And so your question around AI is no, we're currently not using any AI, but we are certainly open to it for sure. And especially in the last couple of years, we know that the applications and the use of AI has been significant, and there's so much you can do with it. So no, I think this program is evolving and it's continuing to evolve, and there's definitely going to be some use for AI, different AI applications in the training. Even after we produce the graduates, we're still involved in the training. So there's going to be graduates, and then we do refresher training every couple of years with them. So we want to continually engage them to maintain their competence. So I do think there's definitely a lot of opportunity for perhaps some AI applications and functions for sure. We don't know exactly what those are yet, but we would certainly be open to looking at any opportunity to improve.
That is wonderful. Greg, thank you so much for your time here today. I really appreciate it. Any closing thoughts, call to action you want to share with the audience?
No, I think we've covered it. And I just appreciate the opportunity, and it's great to connect with you and Jason again. And yeah, happy to be here.
Likewise. And maybe we'll do another episode in the future where we catch up on new findings, new updates, and maybe ask the rest of my questions, because I had more questions, but we just ran out of time. Thank you so much. Very genuinely interesting. Appreciate your work here. And I'm sure those communities, like you said, highly appreciated. Very meaningful work. Thanks again for your time and your expertise. Take care. We'll talk to you soon.
Thank you so much.
Simcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at siim.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at sim_tweets. Thank you to our listeners for your continued support.